Okay, good afternoon. We will go ahead and get started. Welcome to I think this is the 5th meeting of the Health and Family Services Committee. I want to just welcome everyone. Welcome our guests from the Hospital Association who are here today, I know. Do we have any members who would like to introduce guests? Okay, well, Madam Secretary, if you could please take the roll.
Representative Bentley? Here in the room. Representative Bowling?
Here in the room.
Representative Bray?
Present in the room.
Representative Birch? Representative Dotson?
Present in the room.
Representative Elliott? Representative Fleming?
Present in the room.
Representative Frazier Gordon?
Present in the room.
Representative Marzian? Representative Gibbons Prunty?
Here in the room.
Representative Rayburn? Representative Raymond? Representative Riley? Representative Sharp?
Here in the room.
Representative Sheldon? Representative Tate?
Here in the room.
Representative Weber?
Present in the room.
Representative Westrom? Representative Wilner?
Here in the room.
Chair Mosier?
I'm here. We have a quorum established to do business, and we will just go ahead and get started. On the agenda first, we have Representative Brandon Reed with some guests, I believe, to describe House Bill 316 to us regarding diffuse intrinsic pontine glioma awareness. And I welcome you. Please introduce yourselves for the record and proceed.
Thank you, Madam Chairman. I appreciate your all's time and consideration for this important bill. I'm going to have my guest introduce herself, and she has a little narrative that she wants to tell you all about this very important day that we want to establish in the Commonwealth.
I'm Teresa Metton. I am president and founder of the Candace Metton DIPG Research Foundation. I'm also Candace Metton's grandmother. Candace was diagnosed with DIPG in 2009, and she battled that for 16 months before she passed away. In 2011, she was the only child I knew that had DIPG. Last year in the Commonwealth, we lost 4 kids that I know that suffered with DIPG. So this is important to me to have this on the record as a day of awareness, because the prognosis for these kids is no different than it was 50 years ago. So I just feel like if we have more funding, more awareness, perhaps we can get it over the line.
Motion on the bill.
Second.
Thank you. We have a motion and a second. Representative Wilner.
Thank you for the bill, and thank you for your testimony. And I am completely supportive of having a day, designated for this and to raise awareness. My only question to you, Representative Reed, this looks like it requires the governor to proclaim this day, and I'm not an attorney, but I just wonder if that raises a separation of powers issue, and if you would be open to removing, or is there precedent for legislation that requires the governor to declare a day?
No, a lot of the proclamations that we do in the General Assembly, especially in this instance, in this case, we want the executive branch to make sure this proclamation is done, so that is a requirement.
Follow up. So are there other bills that actually require the executive branch in this way?
In bills such as this, there are numerous other bills that require the governor to do the proclamation.
Thank you.
Yes.
Okay. Seeing no further questions, I just want to say thank you for bringing this, and thank you for your testimony. And I agree that any awareness is a good thing when we are looking to find other ways of research, and whether it's through funding. I just applaud you. Thank you. Secretary, please take the roll.
Representative Bentley? Yes. Representative Bowling? Yes. Representative Bray? Yes. Representative Birch? Representative Dotson?
Yes.
Representative Elliott? Representative Fleming?
Aye.
Representative Frazier Gordon?
Yes.
Representative Marzian? Representative Gibbons Prunty,
Yes.
Representative Rayburn, Representative Raymond, Representative Riley, Representative Sharp,
Aye.
Representative Sheldon, Representative Tate,
Yes.
Representative Weber,
Yes.
Representative Westrom, Representative Wilner,
Yes.
Chairwoman Mosier.
Yes. House Bill 316 passes with favorable expression. The same should pass on the House. Congratulations.
Thank you, Madam Chairman. Thank you, committee. Appreciate it.
Next, we will hear two bills by Representative Bentley, or Representative Bentley is the sponsor. First, we will start with House Bill 349. Please introduce yourselves for the record and proceed.
I'm Steve Shannon, the Executive Director of CARP, Association 11 of 12 Mental Health Centers.
You're next.
Joe Dan Beavers, President and CEO of Life Skills, Inc., Community Mental Health Center based in Bowling Green, Kentucky.
State Representative Danny R. Bentley, District 98, in the great state and Commonwealth of Kentucky.
And we do have a committee sub.
Yes?
To
Motion on
approve.
sub, second.
We have a motion and a second. All in favor of approving the sub or adopting the sub? Any opposed? All right, thank you. Please proceed on the committee sub.
Thank you, Madam Chair Lady. This summer, in the interim, we had a task force on severe mental illness. And during that task force, we found many shortcomings of our state with people with severe mental illness. This bill today comes out of that task force, and some of you people here served on it with me. And I appreciate your service and your ideas, and we had everyone putting inputs into that. But under the fourth bullet point in the back, it says findings and recommendations, and the last sentence of the fourth says the lack of regional service providers has created additional issues with continuity of care for CMHCs because any provider can enter a CMC's region and provide services. That was written in our report. So our support bill is HB 349, CMHC Regional Legislative Law. The Community Mental Health Centers, that we call the CMCHCs, were established by the Federal Community Mental Health Act, which was the last piece of legislation signed by John Kennedy. Kennedy believed in mental health of everyone, and Kentucky was the first state to implement the federal legislation establishing these community health centers as a behavioral health public safety net provided in the Kentucky statutes KRS 210.370-485. The legislature establishing the CMHCs in 1966 created a regional model established to assure that the behavioral health safety net services would be available in all 120 Kentucky counties, and to designate the particular CMHC which would be responsible in each county for assuring that the services were delivered as required. The CMHCs, as a behavioral health public safety net, are required to respond to community needs, including involuntary psychiatric hospitalizations. And for y'all to know, 202A is where a person has, like Dr. Wilner there, can put a person in an institute. You're a 202A? Yes, where I'm not as a PharmD. But these are involuntary admissions. So the crisis response to community partners and the community during our natural disasters, such as the tornadoes in western Kentucky, were provided by these CMHCs in December of 21. The KRS 210 outlines the governor's responsibilities and the duties of CMHCs. There are 14 statutes included in this KRS 210, and the word regional is used 13 times. In addition, the heading of the LRC website for KRS 210 is Regional Community Mental Health Program. It should be noted that KRS 210 does not list the regions and the counties within each region. However, the contracts issued to each CMHC from the Department of Behavioral Health, and that's interesting because, see this? We had this in the committee the other day, which is the Department Overview Services by the Behavioral, and it shows regions in our committee meeting. Everybody remember that? So they're still by regions. Also, the Medicaid manual clearly states a community mental health center shall provide a comprehensive range of accessibility and coordinated mental health services, including direct and indirect mental health services to the population of a designated regional service area as required by KRS 210. Community Health Care Center Behavioral Health Services Manual, May of 2015. So, in conclusion, what does this HB 349HC do? HB 349 simply names the counties and each of the CMHC regions in the Kentucky Revised Statutes. 2. HB 349 requires a CMHC to become licensed as a behavioral health service organization if it elects to provide services outside of its region. 3. HB 349 HCS provides the Secretary of the Cabinet for Health and Family Services a mechanism to ensure services are provided in a region if the community mental health center in that region has notified the Secretary in writing that they are unable to provide the services. The Secretary shall solicit interest from the other CMHCs to provide the service. 4. HB 349 HCS also provides a 12-month transition period from the effective date of this bill, which would be 3 months from now, plus 12 months, to either obtain a license as a behavioral health service organization or to cease participation out of their respective region. This bill does not prohibit a CMHC from providing services and supports in counties outside of its designated region. All a CMHC would have to do is to become licensed as a behavioral health service organization in order to do so. BHSOs are similar to CMHCs, but do not have a designated service area within the state. Again, a CMHC licensed and operating as a BHSO can provide services in any county outside of its designated region. And House Bill 349 simply lists in statute the counties included in each region. HB 349 does not prohibit any CMHC from becoming licensed as a behavioral service organization under KAR 20 and under that license to provide services and supports in any county outside of its service area. And finally, 349 clarifies that there is only one behavioral public safety net provided in each region, responsible for the full range of services in the region, and that is the CMHC designated for that region. My guests are going to introduce themselves and say a few words. So tell them who you're from and get a few minutes.
Motion on the bill.
We have a motion and a second on the bill. I know that we have someone else here to speak on the bill. I will allow him a few minutes to come up to the table and state his points. And then if we have any questions, we can take questions. Yes, come on up to the table. Please introduce yourself for the record. Y'all can stay put if you want.
There we go. Thank you, Madam Chair, and excuse me, members of the committee. My name is Bart Baldwin, and I am Director of the Kentucky Health Resources Alliance and lobby on their behalf. And I represent the two of the CMHCs in the state, Adonta and Mountain. And we have concerns with a part of this bill that prohibits CMHCs from or requires them to become a BHSO to provide services outside of their region. And I just have a few comments, and I'll be as brief as possible. Just from a patient perspective, I think that we need to understand that when a family or folks are looking for, services for a teenage daughter that's struggling with depression from being isolated in the pandemic, or an uncle who needs opioid addiction treatment, or any other number of mental health services, they're not really concerned if it's X CMHC or Y CMHC or a BHSO or a multi-specialty group. They need services and likely need them immediately. And so that's what we have. And I think that one of the things that I want to point out is some system changes that have happened over the last decade plus. In 2011, we moved to Medicaid managed care in Kentucky, and we carved in behavioral health, which meant some states carved that out. In Kentucky, we carved it in. And so at that time, a lot shifted in terms of CMHCs. Their funding shifted primarily to billing Medicaid managed care, 90+%. And that essentially eroded those regions and limit to provide within a region at that time. In 2014, Kentucky expanded our ability for licensed Medicaid providers to individual practitioners. We created multi-specialty groups. We created provider groups. We created behavioral health service organizations as a separate licensure category, all with the intent of improving access to services. Because we had at the time, essential health benefits were a part of the Affordable Care Act, and we were expecting that we would have 600,000 plus new Kentuckians that would have either Medicaid expansion or a plan on the exchange that would pay for these services. And we expected we would have that many Kentuckians that needed to access this. So we needed to increase our capacity to deliver mental health services. In 2016, the Cabinet for Health and Family Services issued an opinion in response to this very question. And I just want to read you a brief excerpt from that. Therefore, requiring CMHCs to obtain an additional separate licensure as BHSOs would only seem to be duplicative, serve to increase their cost, licensure and related fees, and create additional administrative burdens. Identifying the regions is not a problem. Limiting and forcing an entity that already has the ability and the license to provide all these services to create a duplicative licensure category and set up separate billing systems. We already have 6 MCOs. They bill off a separate fee schedule. Their employees of the BHSO cannot be in the pension system. The employees of a CMHC can be in the pension system. The General Assembly was very clear last session with House Bill 8, especially Section 7, that the intent of the General Assembly and the wish is for CMHCs to add employees back into the pension system, not to create a separate entity to where they would not be in the pension system. The BHSOs was modeled after the CMHC license in order to create other entities that were new providers to improve access to services, not to be a duplicative for a CMHC that already has those licenses and the ability to do so. We've had others that have operated outside of the region before. We have CMHCs that operate in multiple states. We have CMHCs that have merged, all of which is great. We have no problem with that in terms of, we're operating in a managed care environment, and this committee, I don't have to explain what that is, certainly, of things to do so that the CMHCs can thrive, survive and thrive, because when they do, they can do a better job and provide more services to those who need it. So our opinion is that by requiring this additional step is just a barrier to services and puts up an arbitrary region. If I live here and I go 2 miles down the road, I've crossed over into a new region, I just need services. That's not relevant to me who it is. I just need access to those services. There are other threats to the safety net. This is not an anti-CMHC comment. I represent those, also work with other provider types. There are threats to the safety net. It's old reimbursement rates that have not been updated in 20 years. It's crushing pension costs for CMHCs to recruit and retain staff. Not this. At a time when we have the mental health needs of our citizens has never been higher. Our overdose deaths are back, with a vengeance and higher numbers. We need to be talking about how we can work together to expand access to services, not create additional barriers and hoops. And I have not seen the committee sub. my little understanding of it is it requires you identify if you can serve it, you talk to the CMHC, and they can approve or not approve and that provide the service. I mean, to me, that's just another step that the patient doesn't care about. They're not interested in that. Are they going to say, well, you can't do services anymore because you're in this region? I just think it creates additional barriers, and it's unfortunate that we have to do this and have this discussion, and I really wish it wasn't before the committee, frankly, but that's just my own opinion on that. So that's all my comments. Thank you, Madam Chair.
Thank you. I appreciate your comments, Mr. Baldwin. And because of your bringing your issues to me, it was on the agenda last week. Mm-hmm. We took an additional week to really answer those questions, really kind of talk through those. And my solution to this is a community mental health center can still become licensed as a BHSO if they want to, but the committee sub would allow them to contract with another CMHC outside of their region if there is an unmet need. And that was my concern. Are there unmet needs? Is this why CMHCs are going outside their region to provide services? So I think in answer to that, we've created we've put in a provision that allows a CMHC to contract with another community mental health center to provide services if that the originating community mental health center service can't provide the service. Does that make sense?
Yeah,
so, I think that we have created something that is fair. It addresses the issue of access to care and ensuring that. So, and it also, as Representative Bentley pointed out, it allows any CMHC who is already providing a service somewhere outside of their region to either partner with that originating CMHC or 12 months for those behavioral health services to be taken up by somebody else to ensure patient care.
And I, Madam Chair, I appreciate that effort, but I still think this is inconsistent. I mean, BHSOs, other provider types don't have regional barriers. They can operate, and we set that up on purpose. So it's not the only. They all do similar services. I mean, certainly,
I understand.
So
as we know, these regional centers are set up to ensure a safety net.
Yes.
For individuals who might not have access to other behavioral health services. And we do need to make sure that patients have that safety net.
Yes.
This was set up in 1964. It's a federal provision. I mean, we're kind of working within the confines of that and just trying to make sure that patients get the care that they need. Do we have any questions? Representative Westrom?
I'm just wondering if you have been part of this conversation during the interim.
This particular issue has been discussed a number of times over the years, and felt like that had been resolved way back in 2016, frankly. There's been a bill in previous legislative sessions that did not get a hearing before the committee. So to answer your question, I was not involved directly with the folks promoting this legislation during the interim.
Will this put any of your service providers out of business?
No, it won't put any of them out of business. I think it could very well require that some that are operating outside of their region, they may choose to not do that, which obviously is the intention, but because it wouldn't be financially feasible to become a BHSO to operate outside of their region because the rates are lower in general than the CMHC rates. They operate off a different fee schedule. So the question is that those folks that they're serving, what happens to them? So obviously it would be a disruption in services. Would they get services immediately, or would they just have to change providers? So I don't know in terms of what would happen there, I don't think it puts anybody out of business. I appreciate the question, but I think it just would change where they're providing services.
Just one
Which
more
is the
question.
intent, I believe, so.
Would this limit consumer choice?
Well, like I said, when we expanded in 2014 to create additional licensure categories and different provider types that could bill Medicaid, because prior to 2014, we had a very closed system. Only CMHCs and psychiatrists, I believe, were the only ones that could bill Medicaid. We added licensed marriage family therapists, licensed clinical social workers, created groups, in order to increase access. So those services that they provide, outpatient therapy, individual therapy, group therapy, are the same services that a CMHC provides. So there's not a distinction. I mean, I will say that the CMHCs in that safety net role do have a greater focus for those with severe mental illness, and that's important. And I'm not trying to do anything to limit that, but many of the services are the same regardless of the licensure type.
Chair Lady, could we answer her questions also?
Yeah, will you turn on your microphone, please?
Yes, ma'am.
Thank you.
Steve Shannon, I'm with CARP. And, we're the group, they're all right here, who have real concerns about this. I think the access question is great. Get licensed as a BHSO. You can do that. I don't think it's very hard. There's a lot of small providers who have done that. The license initial fee is $750, $500 thereafter annually, $250 per site. So the access question, and that's why we've given 12 months after the effective date. So they have 15 months to make a decision to pursue it as a BHSO. And I'm the champion of the regional model, and I'll own that. We are a regional model. You live in Lexington. New Vista has accountability in their 17 counties that other providers do not have. They have to do things. Those are voluntary commitments. The Western Kentucky centers responded to the tornado. They've been on calls. We're different than other providers. And what this bill intends to do is protect that uniqueness versus other behavioral health providers, because we do things in communities that other providers may do but don't have to do. I got an email, a text message on the tornadoes hit in December. Are you all ready to respond? I sent it out. The general response from the CEOs, 2 of which are here today, is we're already there. That's what we do. Pathways in 2012, we're already there. That's the piece we have to protect, Representative Westrom. We have to make sure those services are available in times of crisis when people need it, whether it's a suicide at a school. I contend there's one mental health center in America who's responded to 2 school shootings. One. They went when that happened. 4 Rivers. I think their CEO's online listening. They went to both Heath and Marshall County. That's what we do, and that's what this bill protects. It protects that ability to go. Representative Wilner's example is a public school. You can't go outside of Lexington if you're Fayette County Public Schools and open a school in Jessamine County unless it's a private school or something else, a different license, right? We're saying do what you want. This license is a regional license. Commissioner of Behavioral Health, Commissioner Morris, yesterday held up a map, as you saw, with the regions. The regions matter because then all counties have access to services. And that's what this bill does, is make sure all 120 counties have access to services. And that's what we want to do. Go as a BHSO, because when you're out of region, you're functioning as a BHSO. That's how you're operating, because you're not responding to an SCL provider that's closing, and those centers have to help with that transition because they're there. That's the distinction. BHSOs don't have to do that. They can. We have to do that. We have to protect that, and that's the intent of this bill.
Steve, if I may, is there a financial incentive for CMHCs who are going outside their regions to function as a CMHC versus a BHSO?
Yes, the staffing requirements are different, and they get cost-based reimbursement from Medicaid. The fee schedule is higher. It's $19.99. I agree with Bart. We need to look at that. The MCOs don't pay it. That's the difference. Rates are higher as a CMHC because historically, dollars were driven through Medicaid to support those crisis services as well and not increase state general fund.
Okay. Thank you for that. We do have a couple of questions. Representative Bowling?
Thank you, Madam Chair. And you actually asked my question with that last one. But this has been a good discussion, a good debate on this bill. And where I kind of find myself coming down is I'm a fan of the regional model. I think that ensures the safety nets for everyone. I'm a pharmacy provider myself. If I fill 8 prescriptions, 5 to 6 of them, I might break even or lose money. I live off those 2 or 3 where you can make money. And I think that's the problem is when you go from one region to another and you're looking for maybe those high reimbursement items, that's smart business-wise. I don't blame you for doing that. I don't blame anyone for doing that. But at the same time, it's taken away from that regional facility, that regional CMHC that's already there in place. And it does not allow them to provide the services they need for the citizens in that region. And that's a big concern of mine. So thank you very much, Madam Chair.
Thank you. Representative Prunty?
Thank you, Madam Chair. I just want to ask, do you believe in the family tree? I mean, the regions are on the map that Representative Bentley showed. What's the point of having those if you're not going to function under them? It's almost like kids are coming against the parents to ask for independence or something. Yeah. My understanding is that people are trying to operate as a BHSO, but get bursted at the higher rates. And so, if you want that, then you ought to pay the licensing fee, in my opinion. But that's just my opinion. But thank you.
Lady.
All right, thank you. One last question. Is there any concern about the patients who might be displaced by any of these centers who are operating outside of their regions now and need to be absorbed by existing community mental health centers? Is there
Very
the
much
capacity?
So. Yeah. And that's why we built in the 12 months. So there's ample time to transition. No one's going to be left without services. The CMHCs will know this is going to take place. They will gear up and be prepared to meet those needs. Ideally, there'll be an interface between the two, conversations about what it looks like. Some of these folks are school-based services. We're seeing the family anyway. We're seeing the kids in summers, perhaps, or some other services. So we'll figure all that out, and that's why we went with the additional 12 months. So it's not quick, and it's really 15 months, it's through the process.
Right. Well, thank you. I do think that the committee sub really helps accomplish that piece and really creates an assurance for those patients. So, yes, Representative Bentley?
Lady Chairman, I have one comment. Of the 14, the 12 of them are in support of this, and if they'd stand up, I'd show you who's here today. These people are in support of this bill. Most of them are CEOs. 2, y'all can sit down now. 2, being a pharmacist for a chain, for a hospital, and anywhere else, when another license came along, whether it be CLIA, does everybody understand what CLIA is? Clinical laboratory. I could do cholesterol. I had to have a doctorate degree. I bought that license, and I passed the test. If I wanted to do something for a specialty drug, I bought that license. So in the pharmacy world, DEA, so if I wanted to serve the people with DEA, everybody knows how much you pay for them. So I always paid for the license and considered it as part of business. So that's all I have to say. Thank you.
Okay, thank you. We do have one more question, and then we do have a motion on the bill. Representative Sheldon?
I'm certainly in support of sticking with this regional model and look forward to seeing this through. But you mentioned the pension and some of the folks that would be in. How would this, because it seems if you have both licenses, your staff would still be eligible for the state pension. How's this whole thing going to affect that?
Yeah, it's a good question. The regulation of BHSO allows you have an executive director, program director, could be the same person, and they can be employed or contract employees. So they could have a relationship, get a BHS license, go out of region, and have a contractual relationship with the CMHC, because it's clearly permitted in regulation, they can contract employees, and then they can participate in KRS. Do it that way.
So I guess what I'm asking is if they have a dual license, do they not qualify maybe other the other license to stay in the pension system? Or does BHSOs have to use contract labor?
BHSOs can have there's not a BHSO in the public pension system.
Okay, All right.
They're not quasi-governmental.
I got you.
We are quasi-governmental, but they have contract employees, so they can hire them through the mental health center and contract them out.
Sure. We just have a really, obviously we've been very focused. I know you've been involved in that too, trying to keep folks in the pension system and watch the contract labor.
Yeah.
So I just want to see how it affected it.
Yep.
But sounds
They
like
can do it.
a
Yeah.
satisfactory answer. Thank you very much.
Okay, thank you. We have a motion on the bill. Do we have a second? Second. Okay, we have a second. Seeing no further questions, Madam Secretary, please take the roll.
Representative Bentley?
Yes.
Representative Bowling?
Yes.
Representative Bray?
Yes.
Representative Birch? Representative Dotson?
Yes.
Representative Elliott? Representative Fleming?
Yes.
Representative Frazier Gordon? Representative Marzian? Representative Gibbons Prunty?
Yes.
Representative Rayburn? Representative Raymond?
Yes, and I'd also like to be a yes on 316, please.
Representative Riley? Yes. Representative Sharp? Representative Sheldon?
Yes.
Representative Tate?
Yes.
Representative Weber?
Yes.
Representative Westrom?
I'm going to pass until I can get some more information. Thank you.
Representative Wilner?
Yes, and I'd also like to just thank the folks from the CMHCs for being here and for the incredible work you do across the state. Thank you.
Chairwoman Mosier?
Yes, ma'am. Wonderful. Okay. House Bill 349, as amended by the committee sub, passes with favorable expression. The same should pass on the House. Thank you. And then
Thank you all.
Representative Raymond, would you like to register a vote? We can't do it concurrently, so if you'd like to register a vote on 316.
Yes. Please count me as a yes.
Thank you so much.
Thank you.
And then Representative Sharp, did you have would you like to register a vote on House Bill 316?
I believe I did 316. It's
Oh, did you?
349 is a yes.
Oh, 349. My bad. Thank you. Okay. Okay. Thank you so much. Representative, wow, I just combined a lot of words. Representative Bentley, you have another bill to present, House Bill 364. If you have any guests with you, introduce them and please proceed. Okay, thank you. We're having a hard time hearing you as you turn away, but
Those
we understand.
two constituents live in the hospital area that we're in line with other hospitals.
Okay.
Okay?
Thank you.
You want me to proceed?
Yes, please proceed.
Okay. In 2020, I presented a bill for rural hospitals. If y'all remember, it was based upon the same day that Louisville asked for $35 million. I felt that rural Kentucky should be supported, so we wrote the bill that if you had 55,000 or less people in your county, that you could come to the Cabinet for Economic Development if you needed money for your people, for your structure, or for new medical techniques. A new MRI came out. So it took me probably about 18 months to get $20 million put into that fund, and I think all of you can relate to that. So that was House Bill 183, 2020. And I wrote that bill as if you were in business. So this bill here is for repurposing. We have a hospital closed. We have somebody want to put a hospital back into it. It's not in my original bill.
Motion on the bill.
So
okay.
That's the repurpose and to add that group. And we've already, just one quick comment. We've used this and using this with Pineville in Bell County, right, Representative Bowling? Yes, sir. And
I was going to thank you for that in my vote, for sure.
Okay,
Thank you.
and Bellefonte right now, our plan is to make it half psychiatric hospital with a detox center, which Eastern Kentucky needs, and rehab residents. Gosh, we need it. So that's the reason I had to repurpose the bills, because they're repurposing the hospital. So that's all I have, Lady Chair Lady.
Thank you. All right, we do have a motion and a second on the bill. Are there any questions? All right, seeing none, Madam Secretary, please take the roll.
Representative Bentley?
Yes.
Representative Bowling?
Yes, and may I comment on the bill? Want to thank Representative Bentley for his work. As he mentioned, the previous version of this bill, Pineville Hospital, they got $1 million loan from, so it's at 1%. So it's a bill that's needed and has been put to use in my community. So I thank you, Representative Bentley, and I'm a yes.
Representative Bray?
Yes.
Representative Birch? Representative Dotson?
Most definitely.
Representative Elliott? Representative Fleming?
Yes, ma'am.
Representative Fraser Gordon?
Yes.
Representative Marzian? Representative Gibbons Prunty?
Yes.
Representative Rayburn? Representative Raymond?
Yes.
Representative Riley? Yes. Representative Sharp?
Yes, with comment. First off, Representative Bentley, I want to thank you for bringing this. I know you have put a lot of hard work into this, and it needs to be duly recognized. And I know that our community in Eastern Kentucky is really going to benefit from this and appreciates what you've done.
Representative Sheldon?
Yes.
Representative Tate?
Yes.
Representative Weber?
Yes.
Representative Westrom?
I'd like to vote with comment. I'd like to say, Representative, you are a true problem solver, and I hope your community knows how lucky they are to have you. I vote yes.
Representative Wilner?
Yes.
Chairwoman Mosier?
Yes, and I'd like to echo my colleagues' comments. Thank you very much for this work, for this bill. I especially like the piece that creates an incentive for hiring individuals in these regions. So I appreciate the effort and the bill, and it passes with favorable expression. Okay. All right, House Bill 364 passes with favorable expression. The same should pass on the House. Thank you so much. I believe that is all the business we have, and we are adjourned.